Hello and welcome to our December Publications podcast. I'm Ed Vital from the University of Leeds and chair of the Lupus Forum. And this month, I'm delighted to be joined by my colleague, Dr. Chi Chiu Mok. Cici is chief of the Division of Rheumatology at the Tuen Mun Hospital in Hong Kong. So welcome.
Hi.
So let's go on to our first paper. We've chosen three of them to be highlighted on our podcast this week. And I had a look at the first one, which is a post hoc analysis of the Nobelity trial with obinutuzumab in patients with lupus nephritis. And it focuses on preservation of kidney function. So we have talked about it before, but obinutuzumab is like the next generation, one of the next generation CD20 monoclonals. So after rituximab, another way to deplete B cells. And it has some advantages. The mechanism of B cell killing is a bit different. So it's a type 2 CD20 monoclonal antibody, which means it can directly kill B cells. It doesn't rely on other immune cells to help do the cell killing. And it's also humanized. So we have already this trial, the Nobelity trial, which is the phase 2, was already published, showing that obinutuzumab met its primary endpoint of renal response. And there's a phase 3 trial in lupus nephritis and another one in non-renal lupus that are in progress. So positive information about this drug. There's also some real-world evidence. I've used it a little bit in my clinic as a second-line drug after rituximab and published that. But the issue here is that when we do lupus nephritis trials, the definition of renal response is usually based on an improvement in the level of proteinuria and no worsening in the GFR. And that's a good way to test the efficacy of drugs. But actually, the real reason we want to use these drugs is to stop people getting renal failure. And renal failure is much harder to study in trials because it takes longer. It may not occur for many years later, and you need to follow large numbers of people. So that PCR-based endpoint is a bit of a surrogate. It's not really our objective is to reduce the PCR. It's to stop people getting renal failure. So this trial is a post hoc analysis of the data of Nobelity to look at these really more hard endpoints of loss of renal function. And that's important because it's possible that the relationship between reduction in PCR and loss of renal function might not always be the same for all therapies. You can reduce PCR with an ACE inhibitor or dapagliflozin, but those aren't immunosuppressants, so it might be different. So what they did here was, this was a 2-year study. They followed the patients up for time to an adverse renal outcome, time to a renal flare, or time to a 30% or 40% decline in glomerular filtration rate. And these endpoints all significantly differed, nominal significance, because post hoc this, between the arms. So hazard ratio of 0.4 for time to a adverse renal outcome, 0.43 for time to a renal flare, 0.2 for a 30% GFR decline, and 0.009 for a 40% GFR decline. And you can see one of the survival plots on the slide there. So that would indicate that obinutuzumab doesn't just reduce your proteinuria, it stops you getting renal failure as well in longer term follow-up based on slightly preliminary data, but still. The other thing that they looked at in this study is, I think, a variable that is quite interesting, that the EULAR recommendation for lupus nephritis is that patients should have both a renal response in terms of GFR and proteinuria reduction, but also have less than 7.5 milligrams of prednisolone, have both of these together. And the rates of achieving all of those targets can be quite low. So in this trial, we've also here got complete renal response and less than 7.5 milligrams of prednisolone analyzed. Now at week 76, which is the primary endpoint time, for placebo, that was only 16%. That's on mycophenolate and glucocorticoids, which we've often regarded as a standard of care. Only 16% of patients meet those targets. But if obinutuzumab was added to that, it was 38%. So I think this is very positive information about the idea of adding B-cell depletion first line, and in general in the concept of giving patients combination therapies, not just one agent, but multiple immunosuppressants as a future strategy. We don't yet have, obinutuzumab licensed. We don't yet have the phase 3 study, but it says to me that mycophenolate and glucocorticoids is not an optimal way to treat lupus nephritis, and it should probably be combined with either B-cell depletion or a calcineurin inhibitor, or maybe even both. You did a lot of the earliest studies on combination agents in lupus nephritis, didn't you, Cece? What did you think about this one?
I think this is a very promising anti-CD20, the second generation, and it's more potent in depleting the B cells. And in the marine model, it's more effective than rituximab in lupus nephritis. So based on this phase 2 results, I'm very eager to know the phase 3, which is going on. I don't know whether it has finished or not, but we are expecting good result from the Regency study. And I think that in the recruitment of all the patients were treated initially with the steroid and mycophenolate. And I don't think these patients are refractory cases. So they use the anti-CD20 upfront with the standard of care.
Yeah.
And this will increase the response rate compared to standard of care alone. So this may be a more potent strategy in patients with more severe lupus nephritis. So we have been discussing whether we should use this combination as upfront therapy versus an add-on therapy when the patient does not respond. Perhaps I think we can identify those high-risk patients to consider upfront combination. For example, those with the African Americans, they have a poor prognosis of lupus nephritis, and those with a very poor histology like the crescents, the interstitial inflammation, and also TMA lesion, they have more higher risk of progression to renal failure. Maybe these patients worth a upfront combination therapy. So what do you think?
Yeah, I agree. I mean, I've started using combination immunosuppressants now in most of my patients because I feel that all the trials of combination agents have been better. Is that what you do? You give more than one immunosuppressant?
Because we have the belimumab, and recently we have licensed the anifrolumab. Of course, anifrolumab is not yet licensed for lupus nephritis, and we are using more combination for high-risk patients more and more. Because belimumab, we use MMF, steroid, and belimumab. Of course, when we are using triple therapy, we will not use very high dose steroid, and most of us will use a 0.6 milligram per kilogram per kg for 4 to 6 weeks, and then we taper. Or we follow the Europe recommendation using pulse mifaprednisolone 500 milligram for 3 days, followed by 0.4 to 0.5 milligram of prednisolone per kilo.
Yeah.
So with a lower dose of steroid, we are not too concerned about the MMF combination with the belimumab. The adverse effect may not be increased very much. So we are not using a lot, but a few patients they tolerate very well with this combination strategy.
Yeah, I agree. I think I regard my standard now is either 4 drugs or sometimes 5. 4 drugs being steroid, hydroxychloroquine, mycophenolate, and usually, actually now voclosporin is our most common combination, but it could also be rituximab. Yeah. Okay, let's go on to the next paper, because this is another biologics study. So this one is about telitacicept. This is another agent that we've mentioned a few times. The papers haven't been published yet, but this is an agent that was developed in China, and we've had phase 2 and phase 3 trials presented at conferences, EULAR and ACR, reporting really very high efficacy, so very big differences in SRI4 response between placebo and telitacicept. And this drug's actually already in real-world use in China as well, which is interesting. So we have here real-world evidence for a drug where we haven't actually got the full published papers of the phase 3 trials, and it's not widely available around the world. What telitacicept is a better, a more effective way of blocking the BAFF system. So we're all used to belimumab, which blocks BAFF. BAFF is a survival factor that B cells need to mature and take part in immune responses. But BAFF is quite a complicated system because you've got two ligands, you've got BAFF and you've also got APRIL. And then there's three different receptors. There's the BAFF receptor, the TACI receptor, and the BCMA receptor as you go through B cell differentiation in that order from naive, memory, plasmablast. And there's also membrane-bound BAFF, not just soluble BAFF. So the feeling is that belimumab may not block all of those. It doesn't block APRIL, and there may still be some signaling of BAFF, whereas telitacicept, which is a soluble form of the TACI receptor, would be more efficient in blocking both BAFF and APRIL and membrane-bound BAFF. So it should be more effective. So what actually is in the paper that we're looking at today? This is actually data on real-world use. It's from China, 72 patients. These patients were followed up for up to 1 year. So all the patients got 12 weeks follow-up. Some of them got 52 weeks follow-up. At baseline, they had quite active disease. They had a mean SLEDAI of 9.88, which is similar. Most clinical trials have sort of 9-10 on SLEDAI usually, 10-11. 33% of these patients were skin disease, 33% had arthritis, 47% had kidney involvement, 50% had hematological involvement. So like a combination of what we see in non-renal trials and renal trials kind of mixed together. And in this study, so obviously this is an open label study, so we have no control arm, but as shown on the slide there, you see a significant reduction in the SLEDAI-2K by 12 weeks, 24 weeks, 52 weeks, and also a similar reduction in the PGA score at that time. Now, the SRI-4, that was met in an amazing 81% of patients at 52 weeks, although it has to be said that only 21 patients contributed data at 52 weeks. If you go to the 12-week time points when all 72 of the patients had contributed SRI-4 data, then 54% of them had an SRI-4 response, which is still quite a high level. So I think this is positive information about telitacicept. It's good to see it in a real-world context, because I usually think in lupus clinical trials, the patients in lupus trials aren't the same as all the patients in the lupus clinic. But there are some caveats to this. Real-world open-label data, the patients will have had other management done as well. So other drugs and things can be changed. And we don't have a placebo arm or a control arm to compare this to. I think the other thing that you'll probably know more about this than me, but the other thing some people I've heard say at conferences is that because lupus tends to be more severe in, like, say, in Chinese patients than it would be in European patients, that can mean that effect sizes look big in trials, whereas a trial that was done in a more sort of global population, it might just be because of putting in more severe lupus is why the effects seem big. But what did you think about this one?
Of course, the limitation is this is a retrospective study without a control arm. But remember, in the ACL meeting several years ago, they presented, the same group of investigators presented a RCT, a phase 3 RCT, a placebo-controlled trial on telitacicept versus placebo in lupus. And that was a positive study with a significantly higher SRI-4 rate than placebo. But that paper has not been published, so I don't have more details about that. And after that, I think the drug has been licensed in mainland China only, and therefore I encounter not just this one, but several other manuscripts describing the efficacy of telitacicept in non-renal and renal lupus. And they all reported quite good efficacy after 52 weeks or 2 years. And And the SRI-4 response is even higher, is even better than the BLIS. Remember the BLIS 52 and BLIS 70 study, the SRI-4 response is only 30 something, and the BLIS LN study is only 32, increased to 43 with the combination. But in this study, they reported even higher percentage with telitacicept. So it seems that this agent is quite effective in the treatment of lupus and lupus nephritis. And there are a few serious adverse events as well. But of course, there's no control group. We don't know whether it is the same as the placebo or the same as the standard of care.
Yeah. So and again, this there are other companies trying to develop more effective ways to block the BAFF system, aren't there, as well? So there was a telitacicept, which is still, it had some problems in previous trials, but it's still there's still some investigation of that molecule. There's also a molecule being developed by a company called Alpine that's again like a more efficient, a more effective way to block the BAFF system. So there may be other, there may be continued interest in this class.
Yes, do you know any information about the further development of telitacicept? Because when I read the literature, the previous studies were prematurely terminated because of the infection, because serious infection after recruiting a few patients. But later there's another phase, I can't remember, phase 2-3 study which was positive. So is there any plan of further developing this drug?
I don't actually know exactly the current status of these trials, but like you, I've seen there's still some discussion about this drug, so we'll see.
I think it's worth further developing the anti-BAFF and the APRIL, and this agent may be effective for refractory lupus, maybe. Yeah.
Should we go on to the last paper?
This is a study on the association between non-adherence to hydroxychloroquine based on the serum level of the drug and lupus flare in a cohort of patients from the SLIC inception cohort. And of course, you know the inception cohort consists of many patients, but not all the patients have a baseline as serum hydroxychloroquine level available. They only selected those patients with a baseline hydroxychloroquine level available, and the inclusion criteria was those of using the drug for more than 3 months. And then they follow the patient for any flares. They have a definition for lupus flare, and what they found that around 70 to 8% of patients were severely have a very, very low level of hydroxychloroquine, which indicate they are not adherent to the drug. And these patients were more prone to lupus flares after a median follow-up duration of 3 years. And they also study the damage accrual after five years, which is also significantly higher in those patients who had almost undetectable hydroxychloroquine level due to non-adherence.
Yeah.
One limitation of this study is that they only try to study the baseline level. There's no information on whether the adherence to hydroxychloroquine improve afterwards. And patients who are not compliant to hydroxychloroquine, in my patients, because like many Asian patients, when they because of the difference in culture, they want to try the alternative medicine. So some of my patients, despite explanation, they are still not very adherent to hydroxychloroquine. So when they are not too compliant to this drug, they are also very prone to non-compliance to other medication as well, like the mycophenolate and azathioprine or steroid. So we don't know whether the increase in flare is just because of the non-adherence to hydroxychloroquine. And they don't have any information of the adherence to mycophenolate or other immunosuppressive drugs. And some of our patients are very afraid of the hydroxychloroquine-induced retinopathy and also skin pigmentation, especially in younger ladies. So this may be usually it is the main reason for non-adherence to hydroxychloroquine.
Yeah, I actually wrote down the exact same comment. Yeah, that if they're non-adherent to hydroxychloroquine, does that mean they're non-adherent to other drugs? And also, maybe if they're not adherent, severely non-adherent to hydroxychloroquine, they may be doing other things with their health, not just the medicines they take, but also attendance at appointments or lifestyle factors. They may be less conscientious about that, and that may be the reason. And I know that the other thing I noticed as they commented on in the discussion of this paper, that this isn't the first study to look at hydroxychloroquine levels and outcomes. And some of the previous ones have also said that factors that predict non-adherence could be things like race, ethnicity, disease duration, educational level, younger age, worse disease activity. These things may predict less adherence to hydroxychloroquine, and those things may also predict the bad. So there is a question about the causality here, about whether it's necessarily not taking the drug that causes these people to get all of these outcomes. For example, I was thinking when I was reading it that if a patient, for example, had some mild neuropsychiatric lupus, they have some memory loss and some cognitive dysfunction. I think this can sometimes be a reason for poor adherence to medications, but it may also be a sign that this person's just got worse lupus. And so it might be that the features of their lupus cause the non-adherence and the bad outcomes rather than the other way around. But saying that, I still thought I don't do hydroxychloroquine testing at the moment in my clinic, but I still kind of thought if you did do it and a person had a very low level, that still suggests that coming in with an intervention, spending some time talking to them, monitoring a bit closer, education may be worthwhile. Even saying everything we just said about it could be the other drugs, it could be the lupus that's making them forgetful, it could be, like it still suggests to me that there could be benefit for these people in more intervention.
I think in my locality in Hong Kong, we don't have this hydroxychloroquine level check as routine. And previously, I have done a study on the serum because we have stored the serum for our patient. We send it to do the serum level as a log. But in most studies, they use whole blood. So do you assay the whole blood or the serum level? It seems that the stability is not affected if we use serum, and there's no urgency of sending the serum test within, say, 2 weeks. Yeah, it's more
I
convenient.
don't do it. And we did a recent survey of hydroxychloroquine usage amongst BILAG members in the UK and their colleagues, and nobody said they were doing hydroxychloroquine testing. So in the
It's
UK,
not
we're
routine.
not really doing it. But I think maybe we should. We do mycophenolic acid testing quite commonly, of course. So maybe we should do hydroxychloroquine testing too.
So at least we can identify those who are severely non-adherent to the drug, so that we can give them some counseling to
Yeah,
understand the reasons why they don't want to take the drug.
yeah.
And this will improve the compliance.
Yeah, yeah. And going back to this reminds me of a comment that we made in a lupus nephritis webinar, going back to the first paper, that a lot of the things that determine good outcomes or bad outcomes in lupus nephritis aren't the drugs you choose. It aren't the medicines you choose. It's kind of the entire delivery of the care. How well are they diagnosed accurately, looked after, how closely are they monitored, who's looking after their blood testing, their prescribing. All of these things go into creating a good outcome, not just which drugs we choose to use. Okay, so that's all we've got time for today. So thanks very much for joining me, CC. It's great to hear your thoughts on the latest development in lupus management.
Okay, thank you for inviting me as well.
And thanks everyone for listening. So as always, you can find full PowerPoint slide decks for each of these papers at lupus-forum.com, which you can download to use in your own journal clubs or your teaching. The Lupus Forum is, as always, free to access. All the content's free to download. If you register for updates, then you'll get an email when there's something new out. And you can also follow it on Lupus Forum, all one word, on Twitter and on LinkedIn. Thanks again, and see you next time.